Great that you could join us. And just for your information, we are being recorded. We'll just give you all a little bit of time to join and get settled, and then we will get started. Very excited that you're all here, and look forward to our proceedings today. Another couple of minutes and we'll get started. Thanks, everybody. All right, we're about 4 to 5 minutes into the hour or half hour, whatever it is, depending on where in the world you are. So we'll get started and let the group add up as we go along. Hi, everybody. My name is Devaki Nambiar, and it's very, very exciting and an absolute pleasure to welcome you all to this event called Resourcing Social Participation for Health. It's on us and the government. So I should also start by saying happy Universal Health Coverage Day +1. Yesterday was UHC Day, 12/12/24. And today is Friday the 13th for people who are superstitious about that. It's a great pleasure to have you all make time. I know it's a very busy part of the year, and there's a lot happening even to commemorate UHC Day. So we appreciate you giving the time to be here with us. I thought I'd start with providing a bit of context as to what brings us here. So the theme for Universal Health Coverage Day this year is It's on the Government. And the argument, which I will quote from their website, is, quote, investing in universal health coverage enhances equity and social cohesion while benefiting the national economy by improving health and well-being, increasing workforce participation and productivity, and building resilience in individuals, families, and communities. And so this argument that universal health coverage is good for economies, it's good for well-being of countries, is one that has been made for a long time. Another one that is significant is that health in many parts of the world has been a substantial cause of poverty, right? And that is an alarming concern, something that never should have arisen, but is actually growing, has been growing in its severity. So over the last 20 years, 2 billion people have experienced financial hardship, and 1.3 billion people have been pushed into poverty due to expenses on health. I think almost every single one of us can relate to this, with any family member or us ourselves having to deal with health challenges. Being unhealthy and actually even keeping well is expensive, depending on our context. And there are people who face systematic disadvantage through the course of generations in their lives who bear a disproportionate brunt of this. And so a big part of what UHC Day today is, this year is calling for, is recognition of that and redress of that. One thing that those of us in this panel likely feel is that part of the reason why we are in this situation is that we have not done a good enough job to listen to people, right? We have not let communities take enough of a role in driving decisions on financing and designing health systems. If we did, we wouldn't be letting so many people fall into poverty, right? We would be knowing where those pain points are, and we would have worked faster, one hopes, to have changed systems around. And this idea of listening to people and letting our decisions be guided by communities, by people who are living out their health and trying to get by, really, is what social participation for health is about. And so really for us, when we are in particular worried about this issue of it's on the government, it's as much about us, it's about people and their voices being heard. So what is social participation for health? The World Health Organization has a definition. You may all have your own kind of versions that resonate with this. Social participation is defined as empowering people, communities, and civil society through inclusive participation in decision-making processes that affect health across the policy cycle and at all levels of the system. So this could include local self-government leaders like Rafeekha ma'am, who is here. It could also be NGOs at the country level with crusaders like Suresh, who support communities to monitor health systems and hold health assemblies and hold systems to account. It could be at the global level. Waiswa will speak to this, and the work that is done at that level to make sure that in the corridors of power, in the United Nations and World Health Assemblies and the World Health Organization, civil society voices are heard, community voices are heard. It also has to do with painstaking work tracking, trying to understand and trying to shape financing decisions that health systems are making, that our award-winning colleagues, Margaret and Ruth from Kenya, will tell us more about. Right. So all of this is so important. And some of us in this consortium called SPHERE are trying to bring this together. So SPHERE is a consortium of actors from civil society, health, and academic organizations who are interested in this issue of social participation for health. And we're interested in collaboration, we're interested in drawing lessons and in documentation, and we're interested in expanding an evidence-based progression towards universal health coverage, and really beyond that, health for all, that is democratic, that is inclusive, and puts us on the path to social justice, right? So we have a core committee and a number of members, including country partners, and I'm very delighted to start us off with a showcase from our partners in Kenya, who are, as I mentioned earlier, award-winning. They are the Health NGOs Network. HENNET just last month won the NGO Partnership of the Year Award for 2024. So congratulations to them. This award actually recognizes partnerships of NGOs that have enabled more effective delivery to beneficiaries, benefited more people, and reduced costs through partnership. So they're a true exemplar of this, with over 112 members as of last year and growing in the country of Kenya. Now, that's partnership, and that's really a model that we can learn from. So I'm very delighted to welcome Dr. Margaret Lubaale, the Executive Director of HENNET, and Ruth, thanks, Ruth, who is the partnerships and resource mobilizer, and hear about the situation of financing for health in Kenya. It has been, you could share the slides. You see the sound is not clear, Ruth, Margaret? Do you want to just
The
test your
sound is
sound?
good now.
Okay,
The
fantastic.
sound is good. Can you hear me?
Yes. Over to you,
All
Margaret.
right. Okay, great. Thank you very much, Devki. That was a wonderful introduction. And thanks for the recognition on the award. Indeed, it was a pleasure to know that we are making an impact as HENNET. So this afternoon, we are going to be listening to our presentation by Ruth. But I just wanted to say just one or two things about HENNET. And so maybe we can move to the next slide. Ruth is our Partnership and Resource Mobilization Coordinator, but she's also been responsible for the Social Participation Project under the SPHERE program. And so she's well and able to represent HENNET. So just a bit about HENNET. The slide is not moving, but since I work in HENNET, I should know what HENNET does. HENNET was founded in 2005 and registered in 2007 as a Kenya by the NGO board. Now, HENNET has a membership of about 112 members, but one thing I want to emphasize is that those are the paid up members. But in addition to that, we do have another grouping of CSOs that are not necessarily members, and they number actually more than 100. So we are working very hard to convert those to members, but they are extremely active in the work of HENNET, even though they have not yet registered as members. I think I want to say that, HENNET has been recognized as the unbiased coordinator of health NGOs. And we sit on several TWGs, and we also sit on the advisory board of the Social Health Authority, which is now, grappling with the new health financing for Kenya. Our business is really to coordinate, is to build evidence-based advocacy, and to push for national priorities to be, encompassed in the health policies, and to ensure that the health policies have the voice of the CSOs and the community. And so we are promoting the role and the engagement of civil society, and we provide a common platform for advocacy in order to influence policies for improved and sustained health outcomes in Kenya. And so we are, proud to be recognized as the appropriate coordinator and convener of CSOs in the health sector. Without much ado, I will let Ruth take over and take us through our presentation. Thank you very much. Welcome, Ruth.
Thank you. Yes, now the slide has moved on to what Margaret was talking about. Those are our our strategic objectives, but we need to move on, I think, to the next slide.
Yes, please.
Yes. So universal health coverage in Kenya, I would like to give a bit of our background and connect several things together as I give the story of Kenya. The model that social participation has taken in Kenya is public participation, and this was entrenched in our constitution in 2010. But the involvement of us Kenyans and the community at large has been silent. In addition to that, our former president, I think that was the second or the third president, he did a document known as the Kenya Vision 2030, and it was basically a plan to develop the country over the next years coming up until 2030. And so all our policy documents are somewhat anchored on that Vision 2030. Now, fast forward to 2017, and our former president launches what is known as the Big Four Agenda. And this was basically a plan to fast track the Kenya Vision 2030. And he chose 4 key areas. That was food security, manufacturing, UHC, and affordable housing. Why he chose on those ones is because these are the 4 key things or key sectors that literally drive an economy. Now, that was 2017. 2018, we launched a pilot project because one of the key things that, one of the key areas was UHC, but we have been trying to figure out then how will this be rolled out in the country? How do we set the country on a way of actually ensuring that this is achieved, because health has become one of the key sectors for the Vision 2030. And we decided to have a pilot project. And this pilot project was selected to take place in 4 subnational levels of governance in Kenya, known as counties. So we chose Isiolo, Kisumu, Machakos, and Nyeri. Now, these particular counties or subnational levels of government were selected because in Isiolo, there's presence of nomadic communities. Kisumu has got a high presence of HIV/AIDS infection. Machakos has a high rate of road traffic accidents, and Nyeri has got a high rate of non-communicable diseases. So, seeing how this would, how UHC would be implemented in these 4 counties, the aim was to observe, get as much information as we possibly can, and then upscale the implementation to the remaining 43 counties in the country. We can move on to the next slide. So how was that pilot project done? There was funding from the World Bank, and the model was to abolish user fees in the level 4 and 5 health facilities of Kenya's healthcare system. And just to mention, our healthcare system has got 6 levels, and there is a slide that actually has got a pictorial view. There's level 1 up to 6. So this model for the pilot project was to abolish user fees in the health facilities that are located in level 4 and 5. The funding was allocated in this way. 72% was allocated to delivery of basic and specialized care, 15% for health system strengthening, and 12% for community health services, and 1% for public health. Now, 70% of those funds that were allocated for basic service delivery was channeled to our Kenya Medical Supplies Authority, because one of the key aspects for UHC is the provision of medicines and commodities. So, but 70% of that funding went to KEMSA, and then 30% of it was used for operations and maintenance in the level 4 and 5 facilities. And that is how the funds were allocated. And then for the funds under the health system strengthening, most of that fund was used to recruit healthcare workers. And then for the fund of community health services was used to train and provide supplies to community health volunteers. And then the funds for the public health were allocated to county health management teams so that we can have quality control of our data and surveillance. Remember, this was a pilot project, and we needed to observe and see what exactly is going on. As much data as we possibly can, we needed to collect it. So the challenges that came out from that pilot project were 3 main challenges. And number 1 was that primary care services were unavailable at the point of need. There was a weak linkage between the community and the primary healthcare facilities, and then there were issues around governance and accountability. So the response to those challenges was a recommendation to set up what we call primary care networks. And this is basically bringing the healthcare facilities into a network to assist in the provision of health services at the point of need and as closest as possible, in short, to an individual wherever they are. I have tried to paraphrase so that we can try and get to understand it. The healthcare services are available. They are in the different levels, the 6 levels of care that we have in Kenya. But these services, we wanted them to be networked so that this is a way of addressing challenge number 1, that the services were unavailable at the point of need. So where you stay, what is your closest health facility? And that's what now the primary care network comes to bring, that whatever health facility is there next to you, that is where you should go for your health services. And it is networked in a way that the health facilities have got a referral system, and at the top of that referral system is what we call a hub. And this hub encompasses several health facilities beneath it, and at the highest point of referral is the level 4 facility. This level 4 facility is at the county level, because remember, we have mentioned that in Kenya we've got subnational levels of governance known as counties. This level 4 is actually at the county level, and then the spoke model is where we have got the level 2 and level 3 facilities, where your closest facility would most likely be from level 2 and 3, a health center, a dispensary, or a maternity care center, where you go for your health services. And if you need to see a specialized medical worker, then you're referred up the channel, and that's where we get the hub. And ideally, it is supposed to house or be able to provide services for about 250,000 people as per how the networks have been organized. And then to assist with this, the policy that was set up was the 2019-2024 Primary Healthcare Strategic Framework that was developed to support this goal in response to the challenges that were observed in the pilot project. Now, in that pilot project as well, the communities were involved, and what they did was public participation, such that especially using the community health promoters, using our representatives from the civil society organizations that are implementing health projects at the county level, and even our county health management teams, they actually encouraged the communities at that ground level, at the very level where people live in their villages. They were encouraged to attend civic education forums where UHC was being talked about, so that they can be able to advocate for the provision of health commodities and budget increases for particular health services. Remember, UHC is a pilot project, and so we wanted to see how exactly is it going to be implemented? What will the communities request for in terms of services or their commodities or budget lines or what service they need and things like that. So wherever public participation forums were available, the communities were encouraged to participate and give their views. Then also there was awareness creation, and communities were actually actively involved in informing their fellow village mates where they live, either within their homes. Like if I am in my home here and I know about UHC because perhaps I've come from attending a particular forum, I inform my members within the house about UHC, and then also in the public forums that I've also talked about. Then there was identification and enrollment of these vulnerable people, and this was specifically done by the community health promoters. That's what we call them in Kenya, but these are also called community health workers. And because this is their day job, they are able to know who lives in which house and what services they need. So they'd be able to say that so and so in this particular house should actually be registered. And by being registered meant that you actually are enrolled into the UHC pilot project, so that then when it gets to, when the pilot project begins, you'd be given a card that shows that you're actually registered. And then when you show up for your health services, at least then they would know you're registered and they'd give you the health service that you require. And then there's a distribution of the cards. When the cards were ready and sent out into the counties, the same community health promoters were called and requested for their help in issuing out the cards to those who had been registered. So that is how the communities, in short, were involved in the pilot project. We can move on to the next slide. So the current status of UHC. So remember UHC, as I have mentioned, it began in 2010 in our constitution that we did that day, and how to that the constitution was basically to entrench what we know that health is an important right in Kenya, and we wanted to make sure that that right actually comes out by getting the views of us Kenyans, and we had to get a policy or have something to anchor our health being a right on. So 2010 public participation is reduced in the constitution, but it's a bit quiet up until 2017 when our former president started talking about it. Then I've given the history of our UHC, now the current status. So our current president, who was a former president who was a former vice president when the UHC pilot project was being done, when he was sworn into office, he promised that he would give Kenyans quality healthcare services by transforming the healthcare system. Now, in 2023, one of the ways that he wanted to transform the healthcare system was to revamp our national health insurance fund, which has been providing services for us as Kenyans since 1966. It is the main health insurance provider in the country. And so the idea was to transform it because, as I've mentioned in Kenya Vision 2030, one of the key pillars is health, in short, UHC. And for UHC to be achieved, we wanted to ensure that people get enrolled and are in the project. And so one of the key things in that Kenya Vision 2030 was to transform this fund into a national social health insurance fund so that it can cover everybody. And then that is why the president thought of revamping it in 2023. But later on in the year, in a cabinet meeting, this issue was discussed, and the president and his team decided instead to actually enhance NHIF or overhaul it altogether and provide different funds so that we can be able to achieve UHC. And so the funds that were approved were the primary care fund, primary health care fund that would be supported directly by the government through our exchequer, rather the taxes. Then there's a social health insurance fund that would be funded through contributions from Kenyans. And this one, all of us as Kenyans are aware that we'd be getting that the insurance would be capped at 2.75% of our income. And then we have got the emergency, chronic, and critical illness fund that would also be from our contributions as Kenyans. But once we pay for the social health insurance fund, an amount of that would be set aside for the emergency, chronic, and critical illness fund. We can move on to the next slide. And so those funds I've talked about, the primary care fund, social health insurance fund, and the critical and emergency care fund, along with the digital health bill, the facility improvement financing bill, and the social health insurance bill were presented to Parliament for discussion. So the digital health bill, why was it important, is because we needed to be able to provide medicine in a digital manner, because the world has become digital, and for us to be able to achieve UHC, we have to ensure that we reach as many people as possible. If you are in one of the far counties, like in Kenya, like for example, you're in Mandera, and your health specialist is in Nairobi, you do not need to travel all the way, either the doctor or the patient traveling all the way to Mandera or Nairobi, but you can actually join on a call as we are on Zoom, and you discuss the issue, and the doctor together with another set of panelists can actually see the medical records and agree for this particular patient to do A, B, C, D. That's why we needed the digital health bill. Then besides that, also to ensure that our records are also recorded digitally, such that we can have biometrics. You can just go and place your thumb, and then the hospital recognizes that this is Ruth. And then also to have our records in a database somewhere, that whichever health facility I go to in this country, my history can be pulled up by that doctor so that I can be able to get good treatment. Then facility improvement financing bill. This was to ring fence the revenue that is collected by health facilities to remain at the health facility. This is because in Kenya, we had a system where the revenue that is collected by health facilities to things like paying for your file when you go to the health facility, or paying for small service, little minor services or tests, that money would be sent back to the government. But now this bill says that that money should be ring-fenced to the facility so that it can also have some extra source of resources to be able to do some development or expand in whichever way that the management of that health facility deems fit. And then the social health insurance bill, and this was to establish the social health authority. And this authority is the one that would replace the NHIF that has been operating in the country since 1966. So the final drafts of the bill were sent to the president, and they were assented into law. He assented them and signed them into law. And as at 1st October 2024, NHIF was transitioned to the Social Health Authority, and we are now using our new, using our new funds that I've just talked about. It has been now into the 3rd month since we officially transitioned. And so we are observing what is going on. We are giving recommendations. We are noting what is happening about people's experiences in the facilities, and we are improving as we go along. Next slide, please. So, as I had mentioned, this is Kenya's healthcare system. We have got 6 levels of care. Number 1 is the community. Number 2, we have got the dispensaries and clinics, and we have got the health centers, the maternities, and the nursing homes. We have got the county hospitals and the medium-sized private hospitals. Then at level 5, we have got the county referral hospitals and large private hospitals. And then at level 6, we have got the national referral hospitals and large private teaching hospitals. As I mentioned, the recommendation that was given for the challenges that were identified in the pilot project, I mentioned primary care networks, which would have a main referral hospital that is anchored at the level 4 hospital. So if you go to a level 2 or a level 3 hospital, and the doctor or the specialist there realizes that you require some more specialized care, they would refer you to a level 4 hospital. If you don't get level 4 hospital, then you go to a level 5 hospital and then a level 6 hospital, so that we can minimize, the essence also is to minimize the amount of traffic that is going into these higher levels of care, even though they are close to you, because most of us, the illnesses that we require are not chronic or critical illnesses, but they are basic illnesses that can be treated even by a general practitioner or even a clinical officer, depending on the level of care where you go. Next slide, please. Now, the funds I have referred to that the president introduced with his cabinet in 2023, the Facility Improvement Financing Fund is for the facilities between level 2 and 6. You collect your funding, and your funding remains there from the sources of income that you have. That is now the left point at the arrow of this diagram. Hope it is the same as what I am seeing. And then for the primary care fund, that is level 2 and 3, because that's where primary health care facilities are. For the social health insurance fund, that is from level 2 to level 4. Also because this is an insurance that when you get sick, you go and get your health services. For the primary health care fund, it will be provided directly to the health facilities by taxes from the government. So when the facilities are funded and you are unwell, it doesn't mean that if you do not have money, you cannot get your health services. No, it means that the facilities have money, they have been funded. You will be able as a Kenyan to get the medical services or the health care that you need at that primary care service. The Social Health Insurance Fund comes to boost the resources that are provided so that you can at least be able to move on up to the other levels of care where you get your health services. Now, the Chronic and the Critical Illness Fund kicks in at level 5 and 6, where you require a lot of emergency care. And as a Kenyan, you will be going to the health facility as it's happening, get your treatment, and you will not know at what point which fund you are using, because then you will, even if your social health insurance lapses, you will still be able to get your chronic and critical illness fund or services, simply because this fund exists and a portion of the money has been set aside. So you do need that kind of care at that level. Next slide. Thank you. I didn't. I thought I was going to continue talking and talking and talking, but that is that is UHC in Kenya. I have tried as much as possible to summarize and take us through what is going on in the country. I don't know whether there are any questions, perhaps on the chat, or someone has lifted up their hand. Maybe you could let me know.
Ruth, there actually is one question, and perhaps I'll ask you to take it. Rafeekha ma'am has just fallen off. Oh, no, she's come back. But how about you answer that question, and then we'll move to the fireside. The question is, what is the eligibility to enroll and get a UHC card? What happens to those who don't have the card but need to access services? You did mention this a little bit, but do you want to get into that a bit more? Without a card, what does one do?
This was, this was a pilot project, and the aim for the card was to basically register some vulnerable people, like, for example, persons living with disability, or the elderly, or perhaps the ones who are chronically ill and needed care, so that when they show up at a health facility, at least you know with that card, this is someone who actually needs the service. But even without the card, you will still be able to get your health services, because remember, it was a pilot to see how then does this work. It wasn't meant to lock out anybody, but it was just a way of observing and seeing, can everybody else also be able to get the health services? I am not sure that I have answered, but I think I have.
Yeah, no, and I think as this gets scaled up, there will be, there will be more of this. It's nice to see that it was kind of, there was troubleshooting, to see inclusion, exclusion, and how that works. So we hope reforms elsewhere in the world also look like this. Thank you so much, Margaret, for that introduction, and Ruth for that detailed exposition of what's been happening. And I think there's a lot, if you look at the Kenyan example, there's a lot that governments can do to advance us on the path to UHC. And HENNET has played a role in steering and guiding this, not always on terms that you would like, but definitely having a stake in the process. So we wish you deep thanks and all the best moving this agenda, because there's a long way to go, as you also said. We'll now change things up a bit with some of our Indian colleagues invited to share their view. I request you to please put your cameras on. We will be having a fireside. So I'll first welcome MK Rafeekha Mannengal ma'am. She is president of Malappuram District Panchayat and a prominent figure in local politics. She represents the Anakayam division in Malappuram and was, with our other speaker, part of a delegation that attended the Thai National Health Assembly, apart from her own portfolio of work on health and development in the state. So, ma'am, I'm just going to request you to...
Hi, good afternoon, everybody.
Hi, ma'am. Hi. If it's possible to get your video on, that would be perfect. I'll just introduce our other speaker and we'll start with our first question. Joining Rafeekha, ma'am.
I'm
Yes.
Panchayat President, Malappuram, Kerala.
Uh-oh. Ma'am was at a board meeting and then is on the road. I think we've lost her. So Suresh, it's your show now. Until she comes back, I will introduce you, Suresh, as a very established community and highly regarded community health professional, though with a background in IT and communication. And in 2010, he joined a group of colleagues at SOCHARA in the South Indian state of Tamil Nadu, based out of Chennai, at a time when they were implementing India's National Rural Health Mission's communitization pilot process. So this was, again, one of those types of government initiatives, building on the strengths of civil society, really relying on those strengths and trying something in the community action for health space. And in fact, there's the word communitization is what is used in India. So that's an interesting framing. Perhaps beginning with you and perhaps ending up with mostly you, Suresh, it would be great to hear about your work on health and your collaboration with communities. How did you start? What has SOCHARA prioritized? And how do you create open spaces for social participation?
Good evening, everyone. Thank you for the team inviting me to be part of this webinar and for the great introduction. I'm Suresh. as a community health practitioner based in Chennai, Tamil Nadu, almost southmost state of India. Working with SOCHARA, the organization, Society for Community Health Awareness, Research and Action, having a motto of community building organization basically. And also I'm associated very much with the People's Health Movement of Tamil Nadu chapter, where I'm residing, focusing at ground on communitization of health under the National Health Mission here. So as an organization, the SOCHARA was built upon the basis of community building towards equity and social participation. That's a core element of the organization when it is constituted. The community is brought into the center and other objectives built upon that. The scope for social participation in SOCHARA's activities broader and multifaceted, aiming to empower communities to take charge of their health and well-being through the active engagement and collaboration. So we are exploring the social paradigm of community, policy reform processes, and health activities are mostly framed in the context of social justice in the way of inclusive and responsive to the community needs. So that's the broader work. I'm also interested. I'm also working towards it. That's why I'm still sticking with this organization and moving towards community. See, I come across some recent study from our area by the agri student. So there, a study shows that almost 60 and above % respondents from the community, particularly the women, they showed express at the medium level of some level of social participation activities in their all time of involvement in the community level actions. This is the level of action we have actually established in this thing. Again, as an organization and the person, as you said, so we involved in the communitization part of NRHM, like ASHA mentoring and community action for health programs, right to health campaigns, everything. So whatever we are planning, that is, again, we put community in the center, and we will enable the community and we'll empower the community to take part into the action thing. So that's the core actually for me as well as the organization, and it's also the PHM as a movement.
So that's great to hear, Suresh. It's not just any one thing. It's a whole package of things, commitments and partnerships, trying to keep reinforcing that same point. So, I mean, given the experience that you've had of, just in SOCHARA's 15 years, but over the course of your career, can you tell me a little bit about your experience going to Thailand and seeing the type of organizing they have here, there, the model they have there? There was even this, at the global level, they have some ambitions as well. But can you tell us your takeaways and impressions of what you saw
Yes.
there?
Again, from 2000 onwards, I was involved in this movement, PHM, People's Health Movement. And People's Health Movement actually roughly once in 4 years, so we have a People's Health Assembly from the grassroots level to the international level. So I had an opportunity to closely work with 2018, that's the fourth international People's Health Assembly, which was happened in Savar. So before that, I was very much involved in the mobilization, social participation activities towards the National Assembly in Tamil Nadu. So we had a multiple set of meetings at the district level with the different NGOs, partners, and community members to get insights about their experiences and ideas towards the Health for All goal. Then we had culminated that one into as a state level process at E-Road. Then from E-Road, we almost more than 120 people from Tamil Nadu moved towards the National Health Assembly at the Raipur. Again, from Raipur, again, more than 20. I don't know the exact number from Tamil Nadu. Definitely, it's roughly about 20 to 30 people were assembled in Savar that time. So I was the one who did it from the district level to the international level on the mobilization part, I'd say, to coordinate action. It was a great experience for me to understand this mobilization concept, social participation and the work behind it, how it's impact the systems, everything. Again, I got a second opportunity through the state government. The proposal was put up with them around 2017-18 to have assemblies in our state. Because we had another opportunity as a community action for health under the National Health Mission to pilot this sort of social participation within the context of government programs and government spaces. So that's one, again, huge experience of travel of 5 years down the line from 2007 to 2015 onwards. So, but unfortunately, we could not able to continue that one with the various reasons. So we are urged to put this proposal with the government to at least to seek and hear voiceless people's voice into the health. So that was accepted, and that was again implemented after the COVID, just after the COVID, from 2020 to 23. So we had again mobilized the community and start hearing their voices at the different levels. So finally, in 2023, it was happened in 26 districts, almost more than half of the area we covered it to have this process in this. So with these two experiences, so I was opted and I was enjoying this third one actually, visiting Thailand model. And it's very surprisingly, it's a very good experience for me to get into this. But again, it's very short time, but still, whatever I learned and whatever I exposed, it's a very good thing actually. And this model actually engages the health policy making process, whereas ours is not a health policy making. Instead of it addressing the needs of the people, so very basic level we tried out. But whereas the Thailand model is completely, they are starting at the policy level, from the ground to the top level. So that's an interesting part of this, and it's a great takeaway from my part. And they are involving almost all the stakeholders, like what we are doing in PHM and state, including community people, government officials, health professionals, individuals, community members, collaborative discussion. That's how we also went in the collaboration. So discuss about and participatory manner. So that was a nice experience. I think the active participation from the public health policy discussion, that's again, I wonder. There were some around 1,500 people assembled in person for the 2 days to discuss this, apart from the parallel discussions. But those who are not able to attend personally, in person, so almost, I think they announced around 700 to 1,000 people were in the online mode. That's a huge participation, a huge mobilization in the policy process at the national level is which I inspired actually. So that is the second takeaway from this assemblies. Again, the consistency, I'm saying. So this is the 17th year of National Health Assembly. So last 16 years, they contributed that, again, they try to institutionalizing the participating method towards the health governance of Thailand is a huge effort they took actually. And I'm able to visualize and experience this effort in the field level also, during the field visit. So they took me to the field to experience urban poor housing plan. So again, it's a great, fantastic experience, which they tried from the bottom-up approach. So starting from the discussion till it's still continuing, it ended actually. So it's not ended with the only building and handing it over to the benefit. No, they are still holding and they are still developing further towards getting everyone as a health, everyone in the state of health actually. So that's again third one I'm taking away. Finally, the way they are utilizing the fund in a proper way to get the policy implemented in a proper way towards the goal, UHC goals. That's again the structure I'm saying. So they are creating government agencies, particularly each and every areas what they are processing, everything. That's how the UD agency is created in the 2016 towards urban poor housing plan. So it's not like just making policy and they leave it for 10 years, then suddenly they'll come up with some framework, then they'll adopt some. It's not like the case actually in Thailand. So they are very consistent, they are very focused, and they are very implementive, very dedicated to us. That's the thing I'm again taking it from them. It's overall, it's a different level of implementation, I'm saying, compared with the WHO model, PHM model, and our model, Tamil Nadu model. No? So Thailand is something unique, and we have to take many more things still from them. There are a lot more. Actually. Thanks to the Kanita and others, no, so for this beautiful opportunity they gave to us.
And really, Suresh, thank you for saying that. First of all, they were such wonderful hosts, but your observations there are so insightful. Maybe, I mean, people say this with Kerala also, and we'll talk to Rafeekha ma'am, and with Tamil Nadu. Very hard to replicate elsewhere in India what you all have achieved. But
Good afternoon.
yes, ma'am, I'll just come to you. I'm just muting because there's an echo, if it's all right. Yeah, but I just wanted to reiterate some of your really great points on that policy embeddedness, the very wide and various modes of participation you were saying, from local all the way to this thing, that continuity part that you raised, and this institutional design, the kind of level and consistency and discipline of that commitment is really admirable. And I think we have some things that are similar and some things that are quite different. So with that, I will invite Rafeekha ma'am, you, and I will maybe mute myself because maybe that is causing some kind of echo. So ma'am, welcome. So glad you could make it. We are at the point we're trying to learn a bit about your work in health, ma'am. What have been your priorities and your community's priorities in Anakayam division, and what was your experience in Thailand? If you could give us both together, that would be really great. I will mute myself. And
Good afternoon, everybody.
good afternoon, ma'am. Please.
I'm Rafeekha, District Panchayat President, Malappuram, Kerala, India. I would like to express my heartfelt gratitude for the opportunity to participate in the National Health Assembly in Thailand. It was truly an enriching experience that provided valuable insights. The Assembly offered a platform to engage with participants from various countries and learn about the remarkable models and initiatives they have implemented. I'm especially proud to have had the opportunity to present the work carried out in India through public participation at the National Assembly. It was a great privilege to share our experience and contributions on such an esteemed platform. Thank you once again for this memorable and inspiring experience. Our district panchayat implemented so many projects with social participation. The first one, Sustainable Waste Management Program. A local self-government institution initiated a Sustainable Waste Management Program to address the growing waste disposal issues in urban areas. The project aimed to promote recycling and reduce landfill waste through community involvement. The local government conducted workshops and awareness campaigns to educate residents about waste segregation and recycling practices. Community members were invited to participate in planning session to discuss waste management challenges and propose solutions. That program introduced a door-to-door waste collection system where residents were provided with separate bins for biodegradable and non-biodegradable waste. Local volunteers were trained to assist in waste segregation and recycling efforts. The initiative not only reduced waste sent to landfill, but also fostered a sense of responsibility among residents towards maintaining a clean environment. Benefit of social participation in waste management. Improved waste segregation. Community involvement has led to better waste segregation practice at the sources, making recycling more efficient. Increased awareness. The second one is increased awareness. Public participation has raised awareness about the importance of waste management and environmental sustainability. Hello?
Going, ma'am, we can hear you. Environmental sustainability.
Hello?
Ma'am, we can hear you. Please keep going.
Okay.
Yeah.
Then empowerment of, next empowerment of local communities. Engaging communities in waste management empowers them to take charge of their environment, fostering a culture of responsibility. The importance of social participation. First one, community engagement. Involving a citizen in waste management fosters a sense of responsibility and ownership. The second one is sustainable practices. Public participation encourages the adoption of sustainable waste management practices such as recycling and composting. Social participation plays a crucial role in effective waste management in India and particularly in Kerala. Community involvement has led to significant advancement in waste management practices. This presentation highlights the milestone achieved through social participation in the waste management sector. So many challenges and adaptation this project implementing stage. Despite its success, the Pupils Planning Initiative has faced challenges, issues such as bureaucratic resistance, funding constraints, and the need for capacity building among local leaders have been significant hurdles. However, the Kerala government has continuously adapted its strategies to address these challenges, ensuring that the participatory model remains effective and relevant. The Pupils Planning Initiative in Kerala stands as a testament to the power of community involvement in development. By empowering local populations to take charge of their own development, Kerala has not only improved the quality of life for its residents, but has also created a model that can inspire similar initiatives across India and beyond. This approach highlights the importance of collaboration between government and citizens, fostering a sense of ownership and responsibilities that is crucial for sustainable development. In India, particularly in Kerala, the concept of pupils planning has emerged as a significant model for participatory development. This approach emphasizes the active involvement of local communities in the planning and implementation of development projects, ensuring that the needs and aspirations of the pupils are at the forefront. Okay, madam.
Thank you, ma'am, for giving that example of solid waste management and, really core determinant of health and this legacy of the people's planning process. One similarity, I mean, the people's planning process in Kerala is older than the Thai Health Assembly process and, but has faced these hurdles, as you said, ma'am, the bureaucratic challenges, funding challenges, but that commitment part you said also, ma'am, is important. We have one question actually from a participant who's asking, now that both of you have visited Thailand, do you have any suggestions for improvement of the health reform process, universal health coverage in Thailand? One of the issues that is there, it affects us also, is coverage of non-citizens, non-Indians in our case, but then non-Thai in the Thai case, neighboring countries, refugees, those kinds of populations. I'd like to just add both of you and ask if you have any advice or reflections answering this.
I had a wonderful experience in Thailand Health Assembly. A field visit. Chhatrachowk district is known for its housing scheme that reflect both the traditional and modern style. In this district, traditional Thai houses, typically made of wood or bamboo, with modern residential buildings. This blend showcases the architectural style prevalent in Thailand. The government, in collaboration with private investors, has undertaken initiative to develop affordable housing project for low-income families. Rapid urbanization in Chhatrachowk has led to an increased demand for better housing options. Many housing schemes in Chhatrachowk are designed with an emphasis on community living, fostering social interactions among residents through shared spaces and facilities. These are the most interesting.
All right, ma'am. So, but from a governance perspective, anything about how it could be improved? I mean, one of the other things that is mentioned is across the world, there is growing nationalist sentiment, and it's just a truth. But how do we continue to build this trust and engagement between communities and government, given that that trend is happening? Whoops, we've lost ma'am, but so Suresh, the eyes are on you. Any thoughts on that or on the UHC reform process?
Yes, I mean, again, sorry to, I'm not very sure, because within 2 days, we could not able to explore everything. And the objective is to observe the National Health Assembly and its processes, and to explain something like that. But I have the same question actually, because this model is actually conducted on a thematic basis. That's good actually, to focus on one theme and go and build beyond from the grassroots level to the upper level. That's good actually. But again, if anything happens like a COVID, so what is their responsibility and how they are building upon this? Is it again like as usual the bottom up approach, or is there are they taking any other approach, something like that? But in India, when the COVID was there, no, it's completely top down approach.
Yes.
So yeah, so I mean, I could not able to understand this process again completely, like other perspective, like over it's raised, no, that I have the same question. But one thing I like, it's their discipline. Whatever they are doing in the field or in the work, in the this sort of policy process, no, so they maintain their discipline. So in that way, I'm very much impressed. There is a chances for this to bring into the limelight whenever is required, whatever the problem is raised time to time. That I think there is. I think hopefully they're also aware of this. That's why they are continuing the same model for 16 years. Otherwise, they'll keep changing. No? So then I believe in this model. So it works well for the Thailand's thing. So this year they promoted a health tourism towards their economy. So that's the theme. So they are working for almost 10 months on this with various people, various level, various thematic things also. So how this is going to be contributed to improve the Thailand's economy? Majorly through tourism, they concentrated. So I mean, again, I want to explore all the way of tourism, no? Particularly in terms of traffic or road transport. So I experienced it. So I traveled all modes of travel in Thailand these 2 days. Then I found many things actually. So I have a confidence to go there. They definitely they'll make some changes over the period of time.
Yeah. Thank you. That's a very interesting perspective, I think, and this focus on tourism on the one hand, and then there are plenty of non-citizens who are working in the country also as laborers, right, or as refugees, and how does one reflect, address their needs? I think there are so many of these issues. Every year there are themes for years and years of health assemblies, I think, for Thailand. And what would be really nice would be a continuing way to engage those of us who work in this, to keep going, okay, this year's issue. And whether through PMAC or the assembly process, I think it's been a very generous of the Thais to allow us to kind of figure out our takeaways as we navigate our journeys with community action for health. One last question for you, Suresh. We have, you mentioned noticing the different forms of travel, the different kinds of transport, and things are changing at a rapid pace, even in our context. It's sometimes hard to keep up. But in terms of the way ahead and this theme of it's on the government, what is your sense of what SOCHARA will prioritize, what you're looking for or hoping to partner with the government on the path to UHC? What would be your kind of sense of that?
Okay, so again, I'm not going to narrow down it. It's broaden it to my knowledge, what I experienced. So I cannot say concretely and something. See, again, we had a short study under UHC in Tiruvallur district, one of the district to get the status of implementation of the UHC in Tamil Nadu. But still, we could be able to observe and understand how it is or what it is, how it's going, what are the gaps and other barriers, what are the barriers they have in it. Yes, suppose like if you follow the policy process of WHO under Thailand, in case if it is in a UHC model of Tamil Nadu, I cannot say again India because I'm not very exposed to the India UHC status. Maybe Thelma and other persons who are involved in this, they will be the right person to express it. But my understanding is this: enormous knowledge and enthusiasm is available in the social context at the lower level. But are we harvesting it in the right time and right path is the question. But somehow, as the organization and the movements, or even the government, I would say, so they are trying to harvest it. But I'm not getting the exact the level and status of that one. Even our studies doesn't reflected that one. So I'm waiting for the final result and the report of that one. Second, building partnership, collaboration at multiple levels with the different stakeholders is one of the key strategy actually. But somehow the Tamil Nadu government is having some decision to do that at some level. So they are very bureaucratic and strong policy process state. So I think they are not doing. But somehow the person inside the system, they understood actually. So they are slowly keep moving towards it. They're building partnerships and innovation models. So hopefully within next decade, so we'll come to that actually in a great manner, I think. Again, the capacity building and the sustainable practices, that's the third level again. Yes, we are struggling. Recently, we are struggling, I would say. Before, there'll be some hope. And when we started the 2010 around the CH process, we had a hope. We are very strong. I mean, comparatively, the Tamil Nadu is one of the very progressive and very strong and very pioneering state in that. But recent health assembly shows that. So the models which work, it's a 40-year-old, 50-year-old. Even the infrastructures, whatever the trainings, everything is getting bold actually. So we have to update ourselves towards the sustainability practices. We have to adopt other mechanisms around it. The successful models given by the NGOs or other country peoples. So that is much more required now, actually. This is the time to do that, actually. So this is what roughly I want to reflect on your request.
This is roughly what I also would have wanted to say, Suresh. Thank you so much. So this reliance on, the idea of evidence, and of capacity building, and of also these stakeholder partnerships. I mean, these are really sort of the recipe to have that sustainability and to build that trust out, right, for health system reform. Thank you so much. It was so neat to hear about the arc of your own work, the reflections from Thailand, and your thoughts on the way ahead. So really, my deep thanks to you and for those insights. Now we will, yes, so thanks a lot. And now we're going to move into the capable hands of Waiswa. Waiswa Nkwanga is Senior Technical Advisor and Coordinator of the Civil Society Engagement Mechanism for UHC 2030. He's based out of Management Sciences for Health, but he leads the whole secretariat of CSEM, the Civil Society Engagement Mechanism. Along with the 18 other advisory group members, they are really marshalling global impetus around UHC and Health for All, with a close attention to social participation for health. Waiswa, you've really been a guide and mentor in our work, so there couldn't be a better person to tell us what's been happening with social participation for health in UHC and what's next in 2025. What are the issues at stake, and what CSEM and others of us should be thinking about as we go into the new year? Over to you.
Hi, everyone. Thanks, Devaki, and really great listening to previous speakers. I mean, it's a really interesting moment in terms of UHC and social participation. As many of you might be aware, we had a high-level meeting on UHC last year that was followed up by the World Health Assembly resolution on social participation. And these two are really, connected in the sense that when member states, world leaders agreed the political declaration on UHC last year, in it, they actually are also committed to promoting participatory and inclusive approaches to governance for UHC. And so what we saw this last May with member states coming back and endorsing this resolution was in a way a step to actualize, like a step forward to actualize the commitments they made last year in the political declaration. The thing is that there is a lot that is happening, and that there's a lot that needs to happen. There are a lot of reforms that need to happen for countries that need to be implemented in order to accelerate progress on the 2020 agenda, 2030 agenda, and specific on UHC and on social participation. Some of you may be aware of what the data says about the situation globally. We have nearly half of the world's population lacking access to essential health services. And we also have another number, like 2 billion or so, of those people that are pushed into poverty when they try to access the health services they need. We've also seen a trend in which countries are not really making much progress in terms of providing the kind of social financial protection that is needed to support marginalized, communities, people living in poverty and all of that, to make sure they can access the services they need. 70% of the countries have seen financial protection for health deteriorate. So we are not on track to achieve UHC at the moment, but we still have time, and we can we hopefully can work together to accelerate progress toward both UHC and within that also financial protection. And because of that background, we made a decision this year to focus the UHC Day campaign on financial protection, because one area that is least understood. So you have in the UHC, you have service coverage, you have population coverage, but you also have this other part of it that is about providing that extra support, financial support for those who need it. And so that piece, for some reason, we have not been able to really promote it as well as we wanted, but also to see action from governments as we would love to. And so this UHC Day, we've really focused on that piece so that we can get some momentum, that we can move this piece of UHC forward. And that's that theme around the health is on the government, is really trying to communicate that our commitment to helping people living in poverty, people living in vulnerable situations, to help them with the financial needs they need to be able to access and afford the care that they need. Now, it is, all of these things require funding at different levels. And so this really brings us to the question about, how do we, what kind of reforms are needed to advance UHC and social participation for health. And, I'm not an economist. I'm not a health economist. And so mine are going to be sort of really general perspectives on some of the things that could be done. But from at a country level, I really think that we need countries, especially in low and middle income countries, that we need to focus on primary health care. If we can channel resources into primary health care and community systems, it will both strengthen health systems for UHC, but also ensure that communities are part of that process of driving UHC forward. And that we're talking to communities, we're talking with healthcare providers, we're talking with people who receive the care that we're trying to provide, and hearing them and making sure that their perspectives, their stories are being integrated into what kind of policies and programs we put in place for UHC. The other piece that I really see that countries need to prioritize is obviously having ways to reach populations that are usually hard to reach, poor and vulnerable communities that are everywhere in rich countries and poor countries, where we see that governments struggle to reach those populations. And we see some examples where countries have tried. I mean, obviously, as the previous speakers have indicated, Thailand is a good model, but there are also other countries like Brazil and others we can look at and really see how they were able to design systems and mechanisms to reach vulnerable and even marginalized populations in their countries, and complementing that with financial protection mechanisms to support those poor households. There's also, this is obviously everybody says this, that there's a need to increase allocations to health. Countries are doing this, some of them, but we are not anywhere near what we want to see, especially in low and middle countries, in terms of increasing their budgets, increasing their contribution to health. And so this is something that as advocates, we really need to keep pushing, that we'll need to keep pushing if we're going to get both increase financing for UHC, but also for social participation. Because within that, we want to make sure the governments have also earmarked money to support civil society and communities to engage in the process, in decision-making processes, in designing programs, in the implementation phase of those programs, in the evaluation phases of those programs, making sure communities are engaged and involved and consulted will be key. And all of this will be done differently for different countries because different countries at different levels. But broadly speaking, the community systems are not working anywhere, including in developed countries. Vulnerable communities remain vulnerable. And we are not seeing the kind of investment in health, in public health, even in developed countries that we would like to see in order for us to achieve and advance UHC. At the global level, there is, we have a challenge. 2 years ago, everybody was talking about health. Now, there's a deprioritization of health. At the same time, countries are dealing with challenges around debt generated from, some of it generated from the response to the COVID pandemic. But we have to make noise and make sure that this doesn't fall off the radar of governments and global actors. But we do have mechanisms right now that are supporting health programs, especially in low and middle income countries. You have the Global Fund, you have Gavi, you have the GFF, and many others. And what will need to be done there will be slightly different from what needs to be done at the country level. And we're hearing these conversations that we're having now at the global level about how to streamline and align investments in these global health institutions that are financing health with national governments, like their national plans, their budgets, so that we reduce the inefficiencies, the waste that goes into, working in silos and all of that. So we're having these conversations. They call it the Future of Global Health Initiative. Some others call it the Lusaka Agenda. But it's really trying to streamline the process so that we can use the resources we have now effectively and efficiently and sustainably. It's not always about bringing new money. Sometimes it's about using the resources you have more effectively. And we do need money, obviously, but want to make sure that we are working with what we have and that we are leveraging what we have at a very, very effective, efficient way and sustainable way. And then we also have other processes or models that we've seen work within these JHIs that we can emulate, especially for social participation. You can look at some of the models of like the Global Fund, where they have really invested in the engagement of communities and civil society. You have the delegations that represent the board, but you also have at the community level the CSEMs that they have also established at the community and national level. And so building on those examples to make sure that communities or civil society organizations are getting the support they need to do the work that they need to do in their own communities will help us get where we want to get in terms of accelerating progress on UHC. There's also a need for us to be, creative in terms of generating resources to support social participation in UHC. So, it's possible to have public-private partnerships. I was talking to somebody yesterday from West Africa who really shared the experience about working with local banks and local supermarkets and others to generate income. To generate funding for civil society from those businesses. So it's like the people themselves in these countries are supporting, funding, and contributing to social participation to some of the health services that people need. In this case, it's the immunization, buying some, using some of those funds to buy some packages to help immunize kids in some of these countries. So we're going to have to be creative. We're going to have to do our own part as well to support social participation, support UHC, in addition to what global partners are doing, in addition to what governments are doing, and as we also continue to push governments to do more and others to do more. I'll stop there in case I know we are almost at time. So if there are any questions, happy to answer. Thank you.
Great, great. Thanks, Waiswa. I mean, you started off with a real reality check that we are not on track, right? And it's important to recognize that and use that as, again, a call to action and redouble efforts. So thank you. That was a great set of insights about, even where things are on track, we're contending with inequalities. Even as we try to get more resources, we have to optimize what we have right now. And really this out-of-the-box piece that you ended with, there are newer ways, crowdsourcing initiatives, and some of this came out during COVID, really, in many of our countries, frankly, out of desperation. But I think thinking about this more strategically, allying more strategically in the way that CSEM keeps reminding us to do becomes important. All right, so we have just very few minutes. Been a bit greedy with the time. I'd like to open the floor up for any burning questions or any clarifications from either Suresh or Waiswa. We still have Ruth as well, in case there's anything from there. The floor is open. Would anybody like to bring in a perspective or a question? I'm not seeing hands raised. I did see, not yet anyway. I will ramble in case there's someone else. There was a call or a question in Q&A about, NGOs in Cameroon collaborating with NGOs in Thailand. And look, that's the actual model of CSEM. It's this idea that civil society organizations and movements can ally across the world. And there actually isn't. There are lots of general barriers, but this idea of collaborating together is very much not just desirable, but like necessary, I think, if we really have to fill the gaps that still remain, And that's part of the spirit of CSEM, of course, but also of this thing about Waiswa was saying the private sector playing its part. For academics also need to play their part in really bringing our strengths to the table in terms of evidence and things like that. So just wanting to say that, yes, NGOs in Cameroon should partner with NGOs in Thailand. You should join CSEM. Please email me. We can make some of these connections. And that really is part of this creative thinking that Waiswa wants us to start with, which I think is great advice. I'm going to turn one more time in case anybody wants to raise their hand, raise an issue, or bring anything up. All right. I think it's early for you, Waiswa, but for many of us in Asia, we're sort of winding down in what has been a very busy week. I think the way we curated this event, really trying to bring different kinds of perspectives together is really what we feel is needed. So please go forth and see if you can join this group. Ame, did you want to follow up your question that you asked? Yes, Ame, please go ahead.
Can you get me now?
Yes.
Hello?
Yes, we can hear you, Ame. Please go ahead.
Okay, thank you very much. Thank you very much. I'm from Cameroon,
yes,
which is in Central Africa, and I'm delighted for the presentation, for all the speakers. It was very enriching, and like I said in my question concerning capacity strengthening and collaboration, because as civil society organization in the world, we have one main goal, is to reach out to the vulnerable communities, be it in Thailand, be it wherever these vulnerable communities they are. I think it is not an issue of a particular community or race where we are coming from. So I want to appreciate their openness of giving the room that we can collaborate globally to ensure that what is affecting the world at large should be addressed, especially in the health sector, which my brother mentioned, Mr. Nkwanga, which even in a developed country, it is not easy for this health issue to be addressed. It's really a pathetic situation. It's something that is really affecting the whole world. In the context of Cameroon, where our organization operates as a local civil society organization, with our complex situation with the ongoing crisis, the conflict in our English-speaking region of Cameroon, our target populations are mostly the young girls. We work with the young girls and women in our organization. And most of these young girls are being trapped between the non-state armed groups and the state forces. Most of them suffer a lot of gender-based violence. Some of them are sexually exploited. Health-wise, some of them are victims because of rape. They have incurred a lot of illness, HIV, STDs, and it's not an easy thing. And nowhere to complain because of the poor health situation also, and with the community norms, cultural norms. Some stakeholders of some community tend to give room to the perpetrator to keep on doing it, because most of these young girls do not have people to speak for them. So us now as a civil society organization, if we can collaborate with other organizations with similar objectives, I think putting our voices together, we will be able to bring on the table some policies that our government can look into, and even force this policy in some international convention to be adopted, so that a lot of changes can be made, not only in Cameroon, not only in Thailand, but all over the world. Because girls all over the world are mostly victims. And that is why we keep on fighting on gender equality to protect and empower these young girls. Without taking much of your time, I want to say I'm so much delighted for giving me the opportunity. I will email you, Madam Nabia, I will email you so that we can forge ahead for us to do greater things as we unfold. Thank you very much.
Thank you, Ame. That's great. Next year is the 40th anniversary of the Beijing Platform for Action, and gender-based violence is a core consideration in that. I think it's a big part of the movement towards social justice, inclusion in health, and health for all. I'll just turn to thanks, Waiswa. I'll turn to Waiswa and others if you want to add any reactions or reflections to Ame's comments.
No, it's very really heartbreaking to hear about what is happening there to young women and girls, and we hope that as the international community, as the world, we can all come together to do something to help. Let's continue the conversation. I just shared my email. You can reach out and we can stay in touch, see what we can do to support each other. Thanks, everyone.
Thanks so much, Waiswa. These are core issues. How we are with young women and girls says everything about who we are as a global family and as a society. So thank you, Ame, for allowing us to end on that note. And I think as you also said, in any country, you look at a group of people that I think somewhere in your heart, are being left behind. That's the group to sort of start with. on the progressive path to UHC. And we can all do something, I think, is the other thing you've been saying. So really grateful for that. I hope others I got a ton out of this, and I'm glad it's recorded. There's a lot in store for us to use, even as Sphere. Margaret, I think, had to jump off, but Margaret, Ruth, Suresh, Rafeekha ma'am, and of course, Waiswa, thank you so much for your deep and rich insights. I think you're so much in this work, and we appreciate you stepping out to kind of give us a glimpse of what you are working through and what your advice for us is. So really appreciate that. Our participants, thank you so much for being here. There's a lot more left to do in this area of work, and we look forward to continuing having more events like this. And of course, events like this are not possible without people like Laura, who again, I think is hopping off to another UHC Day event. So just trying to keep the conversations going. Namath, Jason, Charu, Sarika, Claudia, all of the people who have helped make this event and these kinds of conversations possible. Really, really grateful to all of you. Please stay in touch. And we'll be sending out information to all those who registered. And we should have a recording also for you all to take a look at. So my deep thanks to all of you. Have a good rest of your day and take good care. Thanks, everybody. Bye for now.
Thank you, team. Thank you.
Thank you. Good day,
Thanks,
good
everybody.
evening, good night. Bye-bye. Thank you, Dibaki.
Thank you. Thank you.